Well, welcome everyone. I'm glad that you could all join us for our Center for Global Health Equity seminar today on advancing global health. My name is Joe Kolars. I'm the Director for Strategic Development for Global Initiatives and the proud founding director of the Center for Global Health Equity. We've got a great panel and plans for a discussion today, but as you probably know, this is a bit of a special day. It's World Health Day. This day celebrates the founding of the World Health Organization back in 1948, April 7th. And if you're like most of us, we're all concerned with the direction of global health right now and even about the vitality of the World Health Organization. So, but it's up to us, I think, to keep the spirit and the future alive. And we're glad that we can have this discussion. We're in about our fifth year of the Center for Global Health Equity, and it was founded on the principles of a new engagement model for really making cross-campus and global partners come together that really catalyze relationships that wouldn't otherwise exist, and to really take on problems that are co-designed, co-created, and to really bring in other disciplines. So it's not just about what is being done, but how we do it here at the Center for Global Health Equity, I think is quite unique. We're also mindful that the global is local. Sometimes people will be very inclusive of global health. It's everything all around us. But other people stay focused in really low income countries, low income settings. And we're broadening our definition of that, but we're completely mindful of the kind of work that we do here really informs the work we do in low income countries. And more importantly, what can we learn from collaborating and co-designing in low income settings that will actually make us better here in Michigan at the university. And again, this is a team sport. It's really dependent on a multidisciplinary, multi-sectorial approach. And so sometimes what our center is doing is a little bit of brokering, and it can sometimes feel like a dating game as we're trying to piece people together to really further ideas. So we're excited about this particular topic and how we're going to be kind of bringing some of these themes forward in the presentations and the discussion. We're going to hear about two specific projects and actually have some panel discussants who are coming from us from around the world. Maybe if we could have the next slide, Torsten, and I'd like to introduce our discussants. We have Dr. Maria Muzik, who is a professor here at the University of Michigan Medical School in Psychiatry. She's also on faculty in obstetrics and gynecology, and her work focuses on the impact of stress, trauma, and mental illness in the context of childbearing and caregiving, and also the healthy development of parent-child relationships and how to support families in overcoming psychological and environmental adversity. And she is going to be starting us off with her partner, who is Dr. Nergiz Turgut. And Dr. Turgut is professor of psychology and director of the Institute de Neuroscience at University San Francisco de Quito in Ecuador. And she specializes in clinical neuropsychology and neurorehabilitation, focusing on cognitive rehabilitation, brain injury recovery, and the development of culturally adapted therapeutic interventions. And her work really aims to bridge the gap between neurosciences and clinical practice by integrating research-based strategies into patient care and mental health support. So you're a good couple who are going to be presenting our first case, but then our second case is going to quickly follow before we open it up to discussion by Dr. Emily Treleaven, who is here in Ann Arbor. I should mention that Dr. Turgut is coming to us from Geneva, and Dr. Muzik is here in Ann Arbor. Dr. Treleaven is here with us in Ann Arbor. She's a research assistant professor in our Institute for Social Research at the University of Michigan. She studies health disparities and health in early childhood and looking at both the social and structural determinants of maternal and child health. Her work includes evaluating interventions to improve health outcomes and equity in early childhood, including community health worker programs and digital health. And she is going to be telling us about their project with Dr. Gershim Asiki. Gershim, thank you. I know you're coming to us from Mombasa, Kenya right now, where you've stepped away from another meeting. But Dr. Asiki is Senior Research Scientist and Head of Chronic Diseases in the Management Unit at the African Population and Health Research Center in Nairobi, Kenya. This has been a center that's really a fantastic partner for us here at the University of Michigan. His main research interest lies in chronic disease epidemiology and health system strengthening. He also has a secondary interest in maternal and child health systems research, particularly in improving the uptake and equity of maternal and child vaccinations among vulnerable populations. So what's going to happen now is we're going to first have Maria and Nergiz do a bit of a presentation, take about 10 minutes on what is their project and how has it really brought forth some of these themes that we care about here at the center and on a celebration of World Health Day. And then we'll turn to the same from Emily and Gershim about their project, how they're working together. And then it's discussion time. So we've got some questions that we're going to be posing, but this is where we're really going to turn to you as an audience to use that question and answer button there at the bottom to bring forward thoughts that you have and questions for our panelists. So with that, Maria Nergiz, we're going to turn things over to you, please.
Hello, everyone. Thank you so much. I thought we would team tag. I will kick us off with slide 1 and then pass it over to you, Nergiz, if that's okay, and you can walk us through slide 2. So I want to introduce again. Hello, everyone. It's really an honor and pleasure to be here with all of you and with my colleagues here. I want to introduce you to a project that's called A Corazon. And we plan a community intervention to reduce stress and enhance resilience among women in Esmeraldas in Ecuador. Esmeraldas is a region in Ecuador on the northern side of the country. You can see in blue, it's Latin America, and then you see Ecuador, and then you see you see the region Esmeraldas, and it's on the border to Colombia. Before I kind of go into why are we doing this, I want to give you some context. Depression, stress is the leading cause of disease and injury burden for women in reproductive age. We call this perinatal period, pregnancy, postpartum, and young, infancy and early childhood period. Poor maternal health has consequences not only for the mother, the child, but also for the family and society at large. So it's a major issue. And globally, we would say that 80% of people with mental health disorder, depression, women, live in low and middle income countries. So it's a particular burden in areas where there is less resource and also less resource to treatment. And specifically in low and middle income countries like just Ecuador, there is limited access to treatment for depression and distress in childbearing women. And so with this in mind, we actually initially started with a sub-project, first assessing perinatal and childbearing women's needs. We ran interviews, focus groups in the community in this area of Esmeraldas to elicit women's voices of their need, and the message was clear. There is a lot of stress, interpersonal trauma and contextual environmental trauma, low resource, a lot of stressors are impinging on women, and so the rates of depression and the question for support to build resilience and reduce stress was high. So with that in mind, we embarked on this next step, actually kind of first thinking about what is the landscape, what is already available. And that's where the partnering with Nergiz and her team was, okay, you have done work in this arena of mental health. What are you noticing? And we interviewed also other NGOs and other groups in the community. And so with that, kind of pairing the voices of the affected women and pairing the voices with those already on-site provider, it became clear that there is a need to co-design specifically targeted intervention that would be feasible, acceptable, practical, culturally relevant, and would support mental health for the women, would engage the community and build capacity for the community so that they can then be self-sustaining and support the women who are in need of such an intervention. This intervention, of course, does look differently. I do a lot of interventions about depression, specifically psychiatric, psychological, but this intervention needs to have multiple components that are beyond just the psychological or a psychiatric kind of diagnostics. It has to be embedded in the culture. It has to be also providing social supports, the social determinants of health. It has to have multimodal and multi-component. And we are embarking on co-designing this intervention with the community members. So Nergiz team of faculty and clinicians, but also with the community members on the ground to really create something that would be useful and user-friendly based on evidence-based practices that are already in the literature and that we have implemented here in the US and in other parts of the world. So we have a base from where to start, but then want to adapt and co-design modification of the evidence-based intervention that we have as template. So with that, I'm going to pass it on to you, Nergiz, and please walk us through how we are thinking about this. And
thank you very much. Thanks, Joe, for this beautiful introduction. Thanks, everyone, to be here. And yeah, I think Maria pointed out very important things about our project. So it's very exciting to basically make E Corazon a reality right now. And also, from a personal perspective, it has connected me and my colleagues with really incredible researchers. And we are learning every day from each other because we are so multidisciplinary. It really has strengthened our ability, I think, also to co-design hopefully very impactful community intervention. And yeah, bringing together this diverse expertise. We have psychology, we have public health, we have social sciences, we have cognition, neuropsychology. And what brings us together is also the goal to improve mental health, which is very thriving. Beyond the projects, we have also during the years created long-lasting relationships. Yeah, we are planning future joint initiatives. We are working all together on the goal of global health equity. I think this is very important here to underline. We are very excited about what we achieved so far. We are more excited of what is about to come. And yeah, I think this is what I can add until here.
Yeah, and I just want to kind of add. So at this point, we have, collected, qualitative data from community members, the clinicians on the ground. So with different voices that already kind of point us to what what does this have to address, and what does such an intervention have to look like? What other components beyond just the psychological, psychiatric need to be addressed? Education, access also to physical health, to reproductive health education, to, integrating family values, spirituality. This is a multimodal, multi-component intervention that we are thinking through and building now, kind of like the session plan. Again, I said we are basing it on an evidence-based program that I and colleagues co-developed, and it's now, evidence-based therapy for perinatal depression called Mom Powered. It was co-designed with the community. It was named by the community, and we have it registered in evidence-based registries for trauma, stress, and depression treatment for family and mother-child relations. But the point is to now take the basis of that, what could work about this, and we are starting now to introduce it with all the players and kind of do like a human-centered design, work group to co-design, take the elements that might work from this evidence-based treatment and infuse them with culturally relevant and important add-ons or additions or exchanges that will make this intervention useful. Once we're currently in that process, this is what we are currently doing. And once we have this over the next 2-3 months kind of work, it's going to be iterative, then going to the community in Ecuador, bringing their voices, reworking it. Again, it will be an iterative rework process over the next couple months, with then, hopefully with the finalization of the co-design, we want to then train the local clinicians as well as lay personnel, so community health workers, to deploy the intervention. So that's called task shifting. So you take an intervention from, highly educated professional providers, which there is low resource in countries like Ecuador or in particular in the Esmeraldas, and have folks who have a different type of training to be able to deploy the intervention with our support. And then we want to assess the feasibility and effectiveness, as well as the take up. So we are very excited, and really, we have been working now for the last 1.5 years on kind of coming together and co-designing and co-crafting, and I'm looking forward to the many decades to go. I think that we have many ideas how we want to work together and continue to work together, and I'm very excited about the opportunity that the center has brought us together. So with that, thank you for having us here.
Yeah, thank you.
Well, great. And this was one of the projects that the center chose to invest in. And why did we choose to invest in a center like this, or in a project like this? Well, what's really important to our center is to really have a connection in the research to how people could live longer or better. And what's a problem that is really evidenced in the community, like maternal mental health? And does the project really contribute to people living better with this? So that's the lens that we look at through these opportunities in terms of things that we choose to invest in and fund. And we're particularly excited about this project. Before opening it up to discussion, Gershim, Emily, could we hear about your project and give us another example of something that, again, from the center we chose to invest in? Hopefully the listeners could say, yeah, I could see where the center would invest in this, but how this project is going forward as kind of a unique value of how we like to see collaborations happen. So Emily, Gershim, I'll turn it over to you.
Great. Thank you so much, Joe. And thanks to the Center for organizing this webinar today and inviting us to participate. I'm going to briefly describe our project, and then I'll turn things over to Gershim to talk about our co-design process. So our project is about overcoming barriers to early childhood immunization, specifically those that stem from a reliance on paper vaccine cards and records. And as we know from the ongoing measles outbreak in the US, under-vaccination, untimely vaccination, and non-vaccination in the first year of life have really serious and awful consequences. So right now, vaccine uptake is truly a global problem. And it's a really tough one that requires multifaceted, creative solutions. So our project is about testing an intervention to address one angle of this problem with a potential solution that we think could be applicable both in lower and middle income countries as well in the United States. And we're hoping to get the opportunity to scale up. So many lower and middle income countries, including Kenya and Uganda, where our project is taking place, still use paper records to track vaccination in early childhood at health facilities and higher levels, and for parents and families who rely on paper cards to know about their child's past and upcoming vaccinations. So this creates two sets of challenges. At the facility level, tracking and managing a high volume of paper records is really difficult and can lead to a high rate of errors. And when we aggregate those errors across many facilities across a whole country, that can create a really high degree of measurement error in key vaccine indicators. And for families, it can be really easy to lose paper vaccine cards. Hopefully, everyone on this call probably got a paper COVID vaccine card at some point. And if you're like me, you had the experience that you frequently misplaced it. So for families, it can be easy to lose those cards, and that loss is often not equitable. Families that have poor, tenuous housing conditions are more likely to lose their cards, for example. So in qualitative studies across settings, we see parents reporting that they're less likely to return to health facilities for later vaccine doses if they lost their child's vaccine card because they didn't know when to return, or they thought the facility wouldn't vaccinate their child if they didn't have a card for the child. So that contributes to further disparities in vaccine coverage, timeliness, and completion. So we saw a lot of digital health interventions and innovations with the COVID-19 vaccine, but surprisingly, they have been rarely extended to the early childhood immunization space, including in lower and middle income countries. So our project is a really novel but simple idea. We're building an SMS system where parents can text in to find their child's vaccine records and receive reminder text messages about their child's upcoming doses. And if they have a smartphone, they can access that information through an Android app. It's all paired with an electronic immunization registries where providers can log the vaccine doses they administer, both public and private facilities, and that easily aggregates up for county and district reporting. And it's a system we designed with Ministry of Health participation and regulations in mind so that it can be scaled if we find that it's successful. It's successful. And it's also accessible to community health workers who are working in our study areas so that they can support families who are using the digital system, the SMS system, and help them to help their children to reach vaccines on time. So we're currently testing this intervention in 2 health and demographic surveillance sites, one in an urban informal settlement in Nairobi, where Gershim's organization, APHRC, has been running this surveillance site for almost 2 decades. And then a second site in rural Uganda, where they've been running a health and demographic surveillance site for about 5 years now. We're using a cluster randomized control trial design where all health facilities and families in our study areas can access the electronic immunization record, the SMS, and the Android app. And families are getting randomized 1-to-1 to either receive a reminder text message for upcoming doses versus not. Along with that, we're conducting a qualitative process evaluation to understand why or why not the intervention is going to work. So for that, we're doing structured observations with parents, healthcare providers, and community health workers throughout the intervention period, as well as in-depth interviews and focus groups with parents and in-depth interviews with community health workers and nurse vaccinators, both before the intervention launched and then again at the conclusion of the intervention. We're also doing a household survey before and after the intervention to evaluate the impact on coverage, completion, and equity. And then we're going to estimate the cost effectiveness of the intervention. And Gershim, I'll turn it over to you to talk about our co-design process, how we got here.
Thank you, Emily. Thank you very much, Joe, for the great opportunity to share our experiences of what I would call a very successful North to South research collaboration. I will walk you through what we did to succeed in this collaboration. The first thing was we were approached by a team of researchers from the University of Michigan led by Emily. They told us, we have developed an idea to improve child vaccination. We said, oh, actually, we also had a similar idea that was funded by Gates Foundation as a pilot project. And then this culminated into weekly meetings of brainstorming on how we move forward. And from these meetings, we agreed that we bring more stakeholders on board. And so we mapped the stakeholders that included policymakers from the two neighboring countries, that is Uganda and Kenya. We also mapped clinics, we looked at providers, vaccinations, community health volunteers. We thought we should really consult them before we develop what we think is a great idea. So we were lucky to be funded by the center to do some pilot work. And this pilot work was purely a consultative process. So we did a pilot study in both Uganda and Kenya, where we consulted the clinicians, the nurses who are conducting the vaccinations, we visited them in their clinics to understand the challenges they go through when vaccinating children. We also looked at the records, what challenges they had. And then we also visited the ministries of health. We visited the head of the vaccination program in Uganda and also the head of vaccination program in Kenya. And then they helped us to identify other implementation teams at district levels that actually run the vaccination programs. So through our constant engagements, we decided to run a workshop. This workshop was run after we had already done the consultations with care providers, the caregivers, the mothers and guidance of these children, and also the clinicians. But in the workshop, we invited the Minister of Health, represented in the two countries, and the counties and districts that are implementing the program. And in this workshop, we basically came up with an open blank page and asked everyone to contribute to the document. We spent a whole week brainstorming. We had some researchers joining online from Michigan. Then we had others who traveled from Michigan to center in Nairobi. And by the end of the week, we had a proposal developed, which was informed by the consultative meetings with clinicians, caregivers, vaccinators, and the Ministry of Health officials. Then this got funded, but then the collaboration did not stop at the level of developing the proposal. In implementation, when we were co-designing the digital platform, we had iterative meetings with the communities. We presented the digital card to various stakeholders. We did validation meetings with stakeholders to present the product that we have developed. And that culminated in a minimal viable product, which we are now rolling out as Emily has described. So throughout the implementation, it's a pragmatic design where actually the healthcare providers, including community health workers, implementing the project, and the supervision is conducted by the Ministry of Health and the district and county partners, then supported by the researchers. So really from this, we really think we have learned a lot that such collaborations can actually design interventions that address the local needs and is therefore able to cover the equity gaps that we see in vaccinations and health services in general. So we're very grateful to the Center for Global Health Equity for creating such a platform, and also for Michigan University for reaching out to us in such initiatives. Thank you.
Thanks, Gershim. And we were able to connect last week to do a bit of brainstorming about what is it that allows us to work well together. So I'll speak a bit to that and then turn it back over to Gershim. And I also want to thank Gershim for remembering to thank the Center for their extraordinarily generous funding and support of this project. None of the phases of this project would have been possible without the wonderful support from the center that we've seen, both to develop our relationship and the overall project. And I think our overall project has been successful because we had that time at the beginning as we were putting together the proposal to really build out our relationship, as Gershim talked about. So some of the things that we were reflecting on is that we work well together because we have some shared substantive interests and methodological training that can serve as a good foundation for our work together. We can speak the same language when we're talking through a problem, some of the potential solutions, and some of the potential ways to study it. But it's a Venn diagram where we have that shared overlap in substantive interest and methods in the middle. But we each have our own set of experiences in terms of research experiences, prior studies and projects we've worked on, and some training where we don't have overlap. So for example, I have a background in survey research, survey methodology, and I commonly used mixed methods, drawing on my qualitative training, while Gershim is a trained physician and has a lot of experience developing, building, and running a health and demographic surveillance site. All different things that we're drawing on in our joint work together. And we also have some substantive areas that we are drawing on more individually. So I have been an investigator on a large cluster trial of a community health worker intervention, and that's really helped inform our study design as well as how we're approaching the inclusion of community health workers in this project. And Gershim has extensive experience working in nutrition, food systems, and NCDs, as well as a lot of prior experience with digital and health interventions, which has really informed the core of our design here. So Gershim, if you want to say a few words about how that's informed our work as well, that'd be great. Gershim?
But I think my internet, are you getting me?
I apologize.
I think there's some internet connectivity issues. Are you getting me clearly now?
Yes, now you're clear. I was just talking about how we have some substantive areas in common, like our shared interest in early childhood health and mortality, but how you also have a background in nutrition, food systems, and NCDs, and a lot of experience working with digital and health interventions. If you can say a few words about how that's informed our project.
Yeah. Within our teams, we have also varied expertise, data science and digital, of the various smaller groups that share ideas to come up with really a viable product. So I really agree that this complementary expertise has created the ground for really very good collaboration. And I think also respect, which is one of our values as a PHRC, that as researchers who have worked together, respecting our territories, and also acknowledging the fact that even if we have some similar backgrounds in certain areas, you have to trade off to allow somebody who has more expertise. Another thing that has also come up very clearly is mentorship. We have junior researchers in the team, and I'm really glad to report here that Emily holds regular meetings with some of our junior researchers who are at the level of graduate level to build their capacity in research methods and so forth. And we are looking forward to having joint workshops, writing workshops to write up the findings. In fact, we have already published one paper together based on our previous work that were done. And we have actually submitted also one grant application. I meet with Emily every month to discuss prospects of what we can do next after this work. So we really think this is a very productive collaboration that we can build on to do more work in this field and other fields. Thank you.
Great. Thank you, Gershim.
Well, great. And let's go into the discussion phase. And of course, for anyone who has comments or questions about the problems that you're working on, boy, maternal mental health, especially in the postpartum phase, huge. I was late to appreciate what kind of problems there are in the lack of documentation of vaccines, particularly in low-income countries, huge problems. But I wonder if we could start off with some questions just about collaboration in general. Global health, unfortunately, is often involved people in high-income countries like me saying, okay, let me bring my idea and agenda and put it forth in a low-income country. But that isn't what we want to go forward. We want legitimate co-design, and we ask people to prove to us that this is a co-design process. We ask people to find collaborators from across our university. We have 8,400 faculty here at the University of Michigan. So it can be pretty paralyzing for somebody sitting on the Zoom going, well, I've got an idea, but how do I find somebody in a low-income country? How do I find collaborators here at the University of Michigan? How did you find each other? Maria, Nergiz, could you comment on that? How did this start? How did you find each other and figure out that you had common purpose?
Yeah, Maria, if you don't mind, I could start. So we initially connected by another professor that we were working together from USFQ side since I think 2 years. And we were working on child mental health and child health on the coastal area in Ecuador. And through our qualitative studies, we identified that the child development and overall health are very tied to maternal mental health. Yeah. So in one of our meetings, we had the chat and the opportunity arose to collaborate with Maria because they knew each other. And well, Maria is the leading expert in maternal mental health who had successfully implemented Mom's Power program. And after some meetings, it became very clear that a region like Esmeraldas in Ecuador would very much benefit from such an initiative and adapting such a project. So yeah, it's developed over several meetings. I don't know, Maria, your perspective would be
Yeah.
also nice to
Oh,
hear.
absolutely. Thank you for kind of kicking it off. But I just want to amplify what Joe you just said. Really, it is always a co-design with, right? Whether it's in low or high income country, to co-design with the community for the community, right? With the people for the people by the people. And I think that similarly here, when you have a research idea here in the US and you want to kind of work with the community, actually it doesn't work to come and tell them, hey, I have this idea, I want to do this. It is always an organic process where it takes time, a lot of time, and relationship building and listening sessions and being respectful and being collaborative and being appreciative of the experience and the wisdom of the people with whom you want to work, for whom you want to work. And this is even more when you then go and think, I want to bring whatever I have learned here at home in my own backyard. I want to share this also with folks across the world, across the globe, and meeting others in other cultural contexts and getting to know other researchers or community members in other countries like global health. I think it takes time and it takes investment and commitment and being humble and being relationship building and being really appreciative of the wisdom of the other. And I think that Nergiz and I were really lucky that there was a person who was our matchmaker, Joe Eisenberg, who has been in Ecuador for decades. He's part of that community. So when he and his team were kind of building these bridges, they were kind of co-designing and already the foundation. They already realized, if we want to help children with viral diseases and communicative diseases, there are infection disease docs and grants people. They realized maternal health is important. How could we bring additional people into the mix who could infuse their expertise into this? And that's where both actually Nergiz and I were brought into the match. And then we basically married and we kind of said, well, we could be a good couple thinking about this, how we can spin off and support this idea, but collaborating with the original team on the ground already, with Joe and his team. So I just want to emphasize that relationship building is the key. And I wonder what Emily and Gershim are thinking, but I think it's really about being curious, being open, being humble, learning from the wisdom of the other, not thinking that you have it all. We don't have, and jointly you're stronger, and you really, it's a co-design and co-creation. So That's my humble thoughts on it. Wonder what you guys think, Emily.
Yeah, please. I love that term, the wisdom of the other. That's just, it says a lot in very few words, but it's something we need to spend more time appreciating. Emily, Gershim, how did you find each other?
Well, we were also lucky to benefit from a U of M matchmaker. We were connected by Matt Bolton, who works at the center and is faculty in epidemiology, who had worked for a while with one of our co-investigators on this project at APHRC, Martin Matua. So Martin and Matt had a long history of collaborating, had jointly supervised some students, and so our team, the U of M side, originally, when we first started to think about this project, before we found Gershim and his team, we're sort of thinking about ongoing collaborations we had in other places, but none really felt quite right. So I believe it was Joe who had suggested, Matt Bolton's doing a lot of work in vaccination. Why not talk with him? And I had long known about APHRC, where Gershim works, as being just really excellent, a true leader in demography and epidemiology and public health in Africa. So I was really excited when Matt suggested he might have researchers to connect us with there. So he put us in touch with Martin, who said, oh, actually, my colleague Gershim has been leading a very similar project. Let's loop him in. And that was how we first got connected. But I really like what you both said about humility, and for me, I really recognize, like, I want to work on teams. I think that science really has to be collaborative in a team sport, and I really only want to work with other people that feel that way as well. I think that really contributes to success, and that was really apparent from the beginning, meeting Gershim and Martin and the rest of their team that first summer, that they shared some of that philosophy. But having that time to have weekly meetings, our U of collaborators, David Hutton and Gwen Lee, were able to travel to Nairobi that summer to work with Gershim, Martin, and their team in person to really, just spend a week sitting down, getting to know each other. I was able to at least call in on Zoom some, which is never the same as getting to be there in person, but, having that really dedicated relationship building time before we started tackling the really hard parts of how do we operationalize this? How do we get the Ministry of Health to buy in? What do we do now that we're, no longer working in a space where the US government supports vaccine uptake research? Having a strong foundation from which to tackle those challenges makes the hard parts of this work a lot easier. Gershim, what please add?
Yeah, what I can add is that the personal connections, including the in-person meetings, the visits to the local sites, I think played a very great role, because you get to understand the challenges that people in the South or low-middle-income countries face when you have to interact with them. For instance, network connectivity. Everybody understands that so well, to the extent that sometimes we have to switch through different platforms. We move from Zoom to WhatsApp, and that flexibility. And I know that flexibility comes when you really understand the local context. So when I say looking for network on a tall tree, she will understand that actually network is an issue, because she has been to the site. I remember when we visited the site in Uganda, we were in a hotel which had no internet for the 5 days. And I was asking Emily, how do you feel to be in a place with no network for a whole week? You are not connected to anyone. So I think that physical touch, visiting, coming on site, helped even to understand the context better, and that strengthens the collaboration. I know we have gone a lot on virtual meetings now, but I think a virtual meeting is not real. Sometimes it's good to establish the initial collaboration virtually, but it's good to get down to the ground, meet people, and also interact with the local communities to understand the context. And then therefore that improves the interactions. And I really don't want to overemphasize the issue of respect. In our institution, we value that a lot, because we're coming from a setting where many African researchers would be called principal investigators when they're actually glorified data collectors. So like a protocol is written somewhere, and then you're a professor in a university, you are given this protocol to implement. That is not science, because someone who is trained, has a PhD, has the ability, understands the local context, needs to contribute the subject matter right from the design of the proposal, not when the protocol is already written and is going to be implemented. Thank you.
Yeah, and I think when the summer here, winter for you, when we first met, we had conversations about how do we approach collaborations? What are our shared values, or what are our values? And we identified the overlap. And I think that was a really helpful conversation to have from the outset, to realize we both really value respect and shared participation, and we don't want, we don't want to hand you a finished protocol. That we share that belief that that's not a way that we want to be doing science, and that, neither of us sees that as successful. So I think that was really helpful to start those conversations early. And they can be awkward when you don't know someone, but it also led us to have a productive partnership from the start, because we realized we are in fact really aligned, and it would have been a really hard project to carry out if we, discovered a year or two and that in fact we're not aligned in how we approach science and teamwork. So, we're lucky that we were so aligned, but I think the success comes from having those conversations early and really trying to identify whether or not we were aligned.
Yeah, a powerful idea is necessary, but not sufficient. If you don't have the powerful relationship to pull it off. And unfortunately, I think when I look over my career, so often Americans are very transactional. They go in and there's an RFA and, how are we going to do this? I'm so refreshed when I'm with colleagues in other countries when they're going, no, let's talk about how we're going to be together before we talk about what we're going to do together. And boy, I've learned a lot from that. Did you, Maria and Nergiz, did you have to have explicit conversations on how you were going to be together, or was it all driven by the passion of making maternal mental health, reduce it as much as possible in Quito?
May, if you want to start, right?
Well, this is exciting. I feel like this is like a couple that has like, oh yeah, how did we have never talked about this in this explicit form. So this is really interesting to see what Nergiz will say. But I can tell you that from my perspective, I think that I, in general, am a person who has learned over my career that research and kind of work in the community does not work when you come as, you come in with your projections and you come with your, narcissistic ego, maybe saying, I have this wisdom, I have 20 years of education behind me, and I have the answer. So I'm very humble to begin with. And I think that I learned that even in my work here locally in the US, in communities, that it's a collaborative process, that it's reciprocal. We are not taking from, right? Often communities see it as there is an RFP and you have an idea, you want grant funding, and now you say, hey, I even heard that word from colleagues. Can I parachute myself into your community to get, research subjects for that great idea that I have? And it's going to help them. But that's not the way to do it, right? That's not, this is not a takeover. This is a collaboration. This is reciprocal. I'm giving, I'm taking, I'm learning, you are learning. And we do this together for a joint benefit. And I think based on that, I think I already went into this collaboration with that spirit that, hey, let me learn whether you think, Nergiz, that this might be of value, what I have to offer. And are you seeing this as something valuable? Do you see this as a problem? Do we have a shared understanding of what the need is, what the problem is, and what co-created solutions could be? And I think that maybe it was more implicit than explicitly stated, that the conversation was in such that it was from the get-go very respectful, I thought, and very curious, just kind of open and reflective. And it, or in my mind, organically unfolded, that we kind of created, like, what are we going to do? How are we going to do this? What do you think? And kind of building on that, it almost, very democratic process. There are always very many people in our Zoom meetings, and everybody has some ideas how to do it. So I think we didn't have explicit conversations, but Emily and Gershim, I actually think, I love it that you made this explicit. And I think that we are learning from you that maybe we go back, Nergiz, and
Mhm.
and kind of maybe quantify it in some way, or write out, our values, like our, shared ways of being with each other.
Yeah.
That we
Yeah,
really
some reflection.
that we really write it out. So I like that idea a lot. Thank you.
Yeah. Yeah, thank you very much. I think I can talk for Sol Garces and me, my beloved colleague who is also working in the Institute and who's also part of this project. I think we had to learn during the past years. I mean, we were relatively young researchers, let's say, to see what is important for a project. Is it, let's say, something prestigious, yeah, or is it the team? And we really had to learn during the years. No, if the team is not right, then the project doesn't work. Just like, to give a short glimpse, we had it also in the past from a European university that research was done together, but at the end, all the acknowledgement went to the European university, which created a lot of conflicts and also mistrust. And so we learn from this, and we are looking very well with whom we want to collaborate, and that we can basically also trust with. Yeah. And I think since this collaboration and relation, or marriage, we could say, happened during such a long time, over the past, I think it's 2 years, Maria, or yeah, so that we were frequently in contact, that we were sharing our thoughts about mental health, but also some personal stories, let's say, that created that trust. And yeah, I think that is so important. And I like that reflection idea, Maria. So maybe we can implement it for our next meeting.
I just want to do an add-on comment. I think, what also connects. I mean, it is like in a relationship, good times connect you, but also overcoming disappointments or failures connects you as well. So when we, like, put our work in, and we said, oh, this is a great idea, and then, we didn't get funded, or we didn't fall apart, but we kind of built each other up and said, you know what, no matter what, this is a good idea. We want to do this together, so we will keep going. And I think that also builds relationships. So overcoming adversity, so to speak, builds stronger roots of connection. And I think that's what our team is, kind of organically grew together, like the roots of a tree. We are kind of connected, and we will thrive together in our work. So
Yeah.
thanks, Nergiz.
I really like that. I think that that's something that we share as well, really very similarly, where we had applied for some, we've actually had a few examples in the last 2 years where we've applied for funding, and it's really seemed like it's going to work out. And then all of a sudden we've not gotten good news. But, I hadn't really reflected on how that, I think those experiences have also made our partnership stronger as well. Even just putting proposals together and thinking through new ideas and how we would approach those new ideas, that can really strengthen us. But building that resolve from, yes, we're going to continue this work even in the face of someone telling us no. You're right, that really does build resiliency.
Well, this is a great conversation, and I'm looking for questions from the audience, so please put them in. But yes, I know there are things that bring people together and really form that relationship. And I heard that word trust come up. And boy, I am being in a trusting relationship is a thing of beauty. And I know that's one of the things that's really on the table right now in terms of, the US and the global health sphere, and what's happening to our trustworthiness. It's really bothering a lot of us. Any comments or reflections on navigating power differentials. One of the things, when people are coming from a high income country to a low income country, there's all of a sudden these power differentials, and people, people are coming in with the money, or we're the source of the money. And I find often people of my ilk can be kind of oblivious to the power differentials and not really mindful, whereas people who are in a little bit more of a dependent or vulnerable state are trying to figure out what they need to do to get favor from the people who are in the power positions. And any observations or reflections that you've had on the role of power differentials when people are trying to collaborate between low income and high income settings? I don't think we maybe illuminate those as much as we could, but any reflections or thoughts that any of you have had on that?
That in our particular, this collaboration, I cannot really point out a moment where I felt there was power difference. But from other collaborations, that has been there. I'll just give you one example of a case where a researcher wrote a proposal and told us to share our CVs. And we asked for the proposal. They just showed us the proposal on Zoom, moving the pages through Zoom and say, this is the proposal. And when we said in the Zoom call, and you share and you comment, we did not actually receive such a thing. And that was a clear example of a power differential where someone thinks the ideas are great, and therefore you should take the ideas as they are. In our setting, we have not experienced that at all right from the beginning. We co-designed the research questions together. We co-designed the methodology, co-designed the implementation. We are actually working closely also with the communities and the Ministry of Health in both countries. That's something actually sometimes we ignore, that the policymakers sometimes are left out of the conceptualization of the idea. Researchers come up with an idea, they implement the traditional approaches that when you have results, you then invite the stakeholders to tell them what the great intervention is. But in our setting, we have involved them from the first day, and you can actually pinpoint where their contributions were. So this kind of approach improves uptake of findings. It quickly moves research to practice and policy. So yes, we're aware of those power differences. So that's why we were very cautious when we're entering into this relationship. We started first by knowing each other. And actually, as Emily said, we spent a good amount of time on the first day to introduce each other and the institutions that we come from. I still have those slides where we really talked in detail about what do we do, what are our values, and then understood. And of course, there were icebreakers on what about outside your research? What do you like doing? Would you like watching football like me, Manchester United, Premiership? And then, so that kind of thing. So knowing people in more detail and then really setting your expectations right from the beginning, I think removes that power imbalance right from the word go. Yeah, thank you.
And I think, Gershim, one thing that has helped us too is since our initial project design period, we pursued some other opportunities, some of which, have been funding opportunities where I've needed to be the lead because of the funding opportunity requirements, but also ones where you have been the lead and APHRC has really been in the driver's seat and we're in a supporting role. So having both of those kinds of experiences in tandem where we're each in, sort of primary leadership roles, I think helps balance those power differentials some as well, or at least as a way in which we can show our humility and mutual respect for each other.
Yeah, I mean, thank you, Gershim. Similar, it happened to us, as I shortly mentioned before. Now, for our particular project here right now, it sounds maybe a bit boring, but we really haven't had issues with hierarchy in our group. I think there's a lot of mutual respect and again trust among our team, and we have different roles, that for sure, but the collaboration feels very horizontal and not hierarchical, and really everyone's contribution is very valued and valued equally, and that also makes it's so nice working together and really enjoyable. And I think that's also the point which makes it productive too. Yeah.
You're both
know.
working on projects that we're looking for impact. How is maternal mental health improved in Quito? How are better vaccine documentation leading to better health in Kenya and Uganda? So you're both very involved with community. So I want to extend that hierarchy question. The first part was talking about the hierarchy, maybe between north-south, high income, low income. How do you navigate those hierarchy issues when you're trying to work in community where, there's a social status gradient, maybe an education gradient, the other who is coming from a foreign land? So it seems like those hierarchy issues are really baked in, that you have to go beyond just saying, well, I'm not going to be hierarchical, but they're embedded. How do you navigate that? How do you work on that together and think about, well, if we're really going to work in community, we've got to be mindful of hierarchy and try and reduce its negative impact. Any thoughts or reflections?
I think the diversity of the team is also a core point. Yeah. So we directly want to include the community by adapting the intervention and bringing it that basically back to Esmeraldas, to the community, so that it basically comes from them. And I think this is how you overcome this hierarchy that you mentioned, Joe. But maybe Maria, you want to add some things here.
I just want to amplify what you're just saying, because yes, and yet you have to build the infrastructures so that actually community can be at the table, valued and appreciated. So for example, you have to, pay them for their time. We cannot expect that someone from the community, the clinicians or moms, the women, that they will have time to be co-designing something if we don't, ask them what is it going to take that you can make it, and that we support them in making either childcare accessible or pay for their transportation or for their time to be at the table. And I think that's I appreciate this emphasis. Like, one is an direct personal values. I mean, we wouldn't be in this work if we wouldn't value relationship, community, if we wouldn't value equity and social justice, and wouldn't be people who are seeing themselves as collaborators and not as dominators. Let's put it like that. We wouldn't do that work. And nevertheless, even with the best intention, we have to make it explicit. So it could happen that you don't even know and you are insulting and you are playing out this power differential. Like, just an example that I just realized in our last meeting, we were planning out the times when we will have these meetings with us and the faculty and in your faculty, as well as the community members, when we would meet for the co-design meetings. And in the last moment, almost, one of the community member says, well, actually, these times won't work well because it's actually a holiday in Ecuador. And, and we were like, of course that doesn't work. We would not expect someone to attend meetings during times that are. So I think just being open, saying, of course, this is not now we spent maybe 45 minutes now talking about these dates and what we're going to do now. So thinking, how can we from the get-go create a situation where it's possible to say, wait a minute, this works for us, this doesn't work, this time of the day works for us, this won't, because it's a collaborative spirit, and it has to work for everyone, and it's okay if we have to start from scratch and think about different dates, different times, we will work it out. And similarly, financially, like I think that the decision, so we were thinking in the beginning, like, what is a fair distribution of funds? Because that is also, is it fair 50-50? Is it fair? Should the community have more than like the partner, the global partner? Then what is the best distribution that is really fair? We had these discussions, and I think that we came to a good solution jointly. What makes sense so we can get started? So I think having these discussions, right? And you can only have these discussions when you have the relationship where, even if I hurt you, or if I unintentionally maybe make a misstep culturally, or kind of, can we repair? I think that that's the key point. Can we have discussions for repair? I think that overcomes a power differential. There is always, in every communication, there is power differential. In every communication, there is a potential for hurts and injuries. The question is, can we repair? And what does it take to repair? And I think being humble and honest, that's what it takes. So
I really like that, Maria. I was thinking a lot about humility as you were speaking, and I think, the more opportunities you can take to show your humility, the more that can really strengthen the relationship. But it's a lot of those small examples, like the example you just gave with scheduling, that, together, putting all those small things together can really help show your commitment as a partner and your humility. So taking all those opportunities.
Yeah, I really like that. And I like the emphasis on making other people feel like they're members of the team. And maybe they're not bringing the university credentials, they're not bringing the money, but they're bringing an absolutely key point, a key set of assets, an expertise that is on an equal level. And making people feel valued is so crucial. And frankly, I don't know that we spend all that much time training people in how to think that way. And that's something I think we're learning from processes like this. But speaking about training, we've got a question from a student that it would be great to hear your perspective on. Do you have any advice for graduate students for building relationships to do co-design work? Obviously, they're in a different situation, surrounded by power differentials. And additionally, how should we be intentionally building skill sets and competencies? So any advice to the learners on the Zoom, and we're all learners on the Zoom, but any advice or response to that question?
Yeah.
Please, Gershim.
Let me give an attempt. So indeed, as you rightly put it, these things are not taught in school. I went through my training, and never did I sit in a class where we talked about how to collaborate with partners and communities in research. But we've learned these things on the job. So what I would imagine is there are usually fellowship and internship opportunities that students are exposed to. We at MBChB, we host students globally, and we actually embed them in our teams. So they can actually learn through being embedded in the research teams such as these, and of course through mentorship, talking to people who have successfully collaborated this way. So that's I think what I can say. But I think going forward, I think it will be nice to put such experiences down in writing, a published work or a book on how successful partnerships like this work. I'm sure there may be a few written literature somewhere, but I think it will be nice to put such so that students can come across them and use for their own benefit as future leaders. Yeah, thank you.
Yeah, I just want to add, I also think that including students in mentorship, have them participate in processes of collaborative back and forth and kind of learn on, in real time. I think that that's one of the most powerful experiences, I think. I mean, didactic lessons and teaching is great, but the hands-on being part of, I think, is, in my own experience, every time I was in the mix, rubbing shoulders with others, that's where I learn. And so maybe that's my worldview. We have currently a student that we are integrating. She's a medical student who wants to learn about global health. And so she will participate in our co-design sessions and basically narrate the process. And we want to write this up then as a paper where we kind of, capture the wisdom of that struggle and that co-design and what was it like. And I hope to give her, and would love to talk with you, Emily and Gershim, as well. Like if you have ideas, what lenses to take, right? Like from the balcony, what all to look at, what's the content of the back and forth, but also what's the process, who talked when. We want to like it's going to be on Zoom, so we will videotape the Zoom thing, so we can actually then look also at, who talked how much, which group, how was it transactional, who set the first serve and who responded. And so I think that there are many processes. It's almost like looking at psychotherapy, notes where you look at patterns of how processes unfold. So we want to look at that in detail as a process evaluation of our own work. And I think that that's going to be very transformative for this student going forward when she then is doing global health and looks at how to partner with others.
Yeah, thank
Well,
you.
excellent.
I
Please,
have, yeah, just a
please.
small thing to add. Also, as a view as an educator in US, I think the coils are also very popular. So that's collaborative online learning. We are doing that since many years now with McMaster University in Canada. So basically, you have a class in a different country that you connect with a class in Ecuador. They can be hybrid or online, and the students work on projects together. So it's not that the classes are live, but they have to do some project works. And I have seen that students from Ecuador then pairing with students from Canada, working 3-4 months on different projects, and how they grow also in confidence and how they exchange the different cultures. And it's so beautiful to see. And I think also skills, of course, are exchanged from both sides. And we actually see also now some Ecuadorian students going to Canada to study at Canadian universities, and some Canadian students coming to Ecuador to make an exchange. So that's maybe another recommendation. In Ecuador, we have like a sign that a class is COIL or a COIL class. Maybe it's in Michigan too. So that's not research, but maybe a little step during the education process to, get in touch with other countries.
Yeah, I know as we start to wrap up here, it may not be p-value research in the way some of us look at research, but boy, Nergiz, I think that's real scholarship. I'm so glad to hear what Gershim had mentioned about maybe this needs to be written up. I love that idea, Maria, that you're talking about, because I don't think we've spent enough time on the art and science of collaboration. It's such an overused term in global health, but I don't think enough of us struggle with how to make it better. And, it's one of those things, as soon as you can start to measure it, you can start to improve it as soon as you're explicit about what it is. And especially when you're crossing, countries, cultures, power differentials, students, teachers, there's so many different dynamics, but I think we can study that more than we do. And I think we can make it explicit or at least have a couple of guiding questions that people can start with. How do you like to collaborate? What are some missteps you've seen in past collaborations that we want to avoid? I'm reminded of one of our oldest collaboration platforms at the medical school is with Ghana. And Tim Johnson championed the whole creation of a charter, a rules of engagement. How are we going to be together? And that has really set the tone. And I find that some of these cultures are infectious. I can't help but think that Joe Eisenberg and his work in Quito, suddenly when he was introducing, well, Joe has got a very collaborative, humble way of working with people and how he extends that culture. Or Matt Bolton and the people who have already gone behind. So when you've got good cultures of collaboration, you bring them to other people. And if there's one thing we want to be known for at the Center for Global Health Equity, we want to be the best partner. We want people in Quito or Uganda or Kenya, anywhere in the world, say, gosh, we'd like to work with the University of Michigan. They know how to collaborate. They know how to partner. And if we could reach high for that aspiration, especially thinking about World Health Day, do we need breakthrough science? Absolutely. But do we need people who know how to work together and come together for common purpose? Even if we didn't discover a new thing and we just made more equitable distribution of that which we already know, the world would be a much better, finer place. So I'd really like to thank all of our participants and for the information that you shared. Just while I'm doing a few business notes, we have a question if the COIL class that Dr. Turgut or Dr. Muzik are referring to, if you have that or any more information that you could put out in our chat or email so that we can distribute that. I know that's what we have from one of our audience members.
Yeah, for sure, they can just contact me. I cannot write my email address here in the chat, but they can directly contact me. I can share some information.
Great. Maybe we can ask Jen or Bettina if you could put Dr. Turgut's email available there for any more information. Just in our last minute or two, just some updates from the center. We are thriving despite all these headwinds. Our center is not dependent on indirects or USAID. We enable other people to get that stuff. So we're so grateful to have generous philanthropy and people who believe in our mission. So we have another round of grants. Our seed grants are due April 18th. We have a current set of impact accelerator grants that are under review right now. But our seed grants support exploratory projects that catalyze novel ideas and really build a case for something that's larger. These grants are for amounts up to $35,000, project duration up to 12 months. All of the information is on our website. So if you go to the Center for Global Health Equity. But this has been an extraordinary conversation. And again, we should all be striving for the best in collaborative practices. So Dr. Asiki, Dr. Turgut, Dr. Treleaven, Dr. Muzik, thank you. Find other ways to acknowledge and be grateful that we've had a WHO on this World Health Day, and hopefully that better practices make it stronger in the future. So thanks, everyone.
Thank you so much.